Welcome to the Postgraduate Pediatric Orthopedic video series. These videos are specifically produced to support children, parents and healthcare providers to better understand their health problems and know about the best available treatments. To receive our regular updates, please subscribe to our channel and click on the notification bell below. So, we've seen earlier Dr. Brad demonstrated for us how to examine a child who can walk. Now, Dr. Brad is going to demonstrate to us the child who cannot walk.
As always, we do a look, feel, move examination. Mather is wheelchair dependent, so we won't be testing gait in Mather, but we can comment a lot on what we see with Mather at the moment. So she's in a wheelchair. Her position in the wheelchair, there's a few things I'd like to comment on. We can start with the legs and the feet. So ideally, children should have the knees in a flexed position, and the platforms of the wheelchair should be the place where the feet are resting. So we can see that this wheelchair probably needs some adaptations to allow that to happen, because at the moment it looks like Mather's almost sliding off the wheelchair. The second thing is we can look for the abduction, the abduction brace that sits in between the legs, keeps the hips in abduction while she's sitting in the chair. This looks quite small and probably needs to be adjusted for her height and for her size. As you can see, Mather is sitting slightly to the right hand side at this point in time. So that suggests that the side supports that are here and here are probably not appropriate and require some adjustment. And it also suggests that the head support that she requires probably needs some adjustment. It's very important to have the supports, especially the side supports, appropriate, and the head support to prevent coronal and sagittal plane deformities in the spine. And if those are not addressed appropriately, then there's a high risk of children like Mather developing kyphoscoliosis as they grow older and as they sit more in the chair. The other thing is really important to look at with children who come in with a wheelchair is to see what's in the bag. Mather may have splints, AFOs and KFOs in the bag, as well as other things that she may require for her care: suction, tracheostomy appliances if she has a tracheostomy. Mather doesn't have a tracheostomy, and other appliances. As you can see, she's fairly well strapped in at this point of time, so it's very important at this point of time to engage her carer or carers to help position the child so that you're able to ascertain exactly what you want from a clinical perspective. So I'm going to ask Dad to give me a hand or to direct what we need to do to see Mather's back. Sure. So please, Dad. Thank you. And we'll just lean her forwards, and at this point in time we can bring her top up and we can see very clearly how the spine is in terms of coronal plane and sagittal plane. So the spine actually, alhamdulillah, looks very good at the moment. Fantastic. The other thing we can do here is to compare and see the supports with the sitting position of the child. So let's bring Mather up as much as we can. Here we go. 1, 2, 3. Fantastic. Here we go. So when she is sitting, we can see this is probably a good sitting position for her. As we mentioned, the abduction brace needs to be made larger. This is a really good platform for her feet. Her knees are now in an appropriate position when they're flexed, but you can see that the supports are hitting the pelvis, so they probably need to come a little bit higher. And actually, Mather's probably outgrown this chair. So it's really important whenever the children come and visit you in clinic that you make this assessment or have a colleague that can support you to make this assessment, because Mather spends a lot of time in this chair and it's important that she's sitting in this appropriately. Fantastic. Thank you. We will now proceed to the examination of the upper limb with Mather. So Mather is very comfortable on the couch, and you can see she seems to have both upper limbs held in different positions. The left one seems to be externally rotated at the shoulder, and the right one seems to be internally rotated. In addition, there seems to be some flexion positions of the wrists and the elbow, but she just demonstrated very nicely that those are actually probably just flexible. So what we're going to do with Mather is just do some passive movements around the joints. So we'll start with the shoulder with forward flexion. She's limited. With abduction, she goes up to 90 degrees. On this side, she seems to have the arm in an internally rotated position. So let's see how much we can externally rotate. So we can fully extend the elbow, we can pronate fully, and when we flex, that pronation remains, which suggests that actually there may be some spasticity in the pronated teres, and to try and improve the position of the forearm, Matha may benefit from some Botox into a pronated teres at some point, depending on her function. Let's have a look at the hands and the fingers. So she likes to hold her wrists in a flexed position. The thumb is starting to go into the palm, so she's developing a thumb in palm deformity. Let's see if we can get this improved. And her fingers show no evidence of flexion deformities or any swan neck deformities. With the fingers straight, let's see how much we can extend. So you can see when I'm trying to extend the wrist, the long finger flexors are now flexing, which suggests some tightness in those fingers flexors. I'm sorry. And then in terms of her thumb, you can see it's fully correctable, but the thenar muscles like to tighten up, and her thumb is starting to go into her palm. We'll start with examination of the lower limb, and to do that we'll take off Matha's shoes. You can see, as a non-walker, these shoes I'm told she's had for a very long time, and they're not worn at all, as you would expect with a non-walker. However, it's important that these children do wear shoes, and it's important that we try and keep them standing for as long as we can, for as much time as we can. So we'll start with examination of the hip. To examine the hip, we make sure the pelvis is level at the anterior superior iliac spines, and we can check for leg length discrepancy. The right leg seems to be shorter than the left, so we'll confirm that with a Galeazzi's test. To do the Galeazzi's test, we'll flex the knees and try and bring the malleoli together on both sides. It can sometimes take a while to encourage the joints to go into the position you want on examination of the child with cerebral palsy, and so I would recommend you are patient and take your time for this. We bring the malleoli together. We then have a look from both the front, and we can see the femur seems to be sitting higher on the right-hand side, on the left-hand side than the right-hand side, and we can look from the side and we can see the tibial tuberosity of the left side is in front of that on the right, which suggests that the left leg is longer than the right leg. Of course, at this point we want to confirm that there's no dislocation of the right hip, which is the most common cause of leg length discrepancy in children like Matha, and we would do those with radiographs. The next thing to look at is fixed flexion deformities at the hip. We flex the knee and the hip on both sides as much as we can, and then this obliterates the lumbar lordosis. We then extend one leg fully, bring the heel down, extend the knee, and see if there's any deformity at the hip, and there isn't. The next thing we do is to check for adduction deformities of the hip. Again, we level the pelvis, we keep the knee extended, and we slowly abduct to see how much movement there is. So Matha is quite tight, which suggests there may be an adduction contracture. We look at the other side as well, and we can see she's quite tight there, and she's tilting the pelvis, as you can see. So we do the same with the knees bent. This will eliminate any component of the adduction contracture, which is due to hamstrings tightness. So we bend the knees, and we try and abduct the hip, and you can see there's much better abduction of the hip, which suggests the hamstring tightness may be contributing to any adduction deformities at the hip joint. We move on to examination of the knee. Examination of the knee follows a similar pattern of look, feel, move. We are looking for any obvious flexion or extension deformities, and also the position of the patella. We can feel the position of the patella, and we can also feel where the tibial tuberosity is, and we can estimate the ratio between the patella tendon length and the patella to see if there's a patella alta or a patella baja. Like in many children with cerebral palsy, Mather may well have a patella alter position, and this needs to be confirmed with lateral radiographs of the knee. We will then see if we can extend the knee fully on both sides, which we can, which suggests there are no flexion deformities of the knee. Let's look at the hamstrings and the popliteal angle. So you can see Mather's had a scar from previous hamstrings lengthening on this side. So the medial hamstrings have been lengthened and the lateral hamstrings. The popliteal angle is measured initially with the hip flexed to 90 degrees. We try and extend the hamstrings to see how much movement there is. And this is the R1, the sudden movement to stretch the hamstrings. We draw a line, which is a continuation of the line of the femur, and we draw a line from the tibia. This angle here is the popliteal angle and should be less than 20 degrees. This sudden movement is the R1 stretch of the muscle. We can then try and see if any of this increased popliteal angle is due to spasticity. And the way to do that is to try and straighten or stretch the hamstrings again, but to do it more slowly to overcome the spasticity. So we slowly stretch and see if the spasticity improves. And you can see there's some improvement in the popliteal angle there. If the difference between R1 and R2 is more than 20 degrees, then that's probably an indication that there may be some benefit for intramuscular Botox injection. In this instance, I don't think it is, but we could clarify that with goniometer, which suggests that it's probably due to shortening of the muscle tendon unit. With the popliteal angle, we can measure it in two other ways, which are probably more appropriate and more important for standing and walking children. So as part of the test of the hamstrings, we normally test the hamstrings also with a hip of 45 degrees of flexion to see the functional tightness of the hamstrings. That's not important in non-ambulating children like Mather, but the thing that is important is to eliminate any pelvic tilt, which may be masquerading as hamstring tightness. To do that, we use something called the hamstring shift test. So let's demonstrate how we do that. Before we do that, let me just show you something here. When we do the popliteal test here, you can see that the hamstrings on the opposite side are also tightening and the pelvis is tilting. So I'm going to ask an assistant to help me here. If we flex the hip and the knee on the opposite side, we are eliminating any pelvic tilt which might be causing or contributing to the popliteal angle. We are then going to try and repeat the popliteal angle on this side and see if there's any difference. So the R1 is probably slightly improved compared to previously. And again, there's not much difference between the R1 and the R2. So there's definite shortening of the muscle tendon unit of the hamstrings, but you can see the difference when the pelvic tilt is obliterated. We'll complete the examination of the lower limb by examining the foot and the ankle and then doing the rotational profile. In the foot and the ankle, one of the most important examinations is the Silver-Scales test. This is a test to look for tightness in the gastrosoleus muscle complex. To do this, we have to have the heel neutral, and with the knee extended, we dorsiflex the ankle. We get a measurement of the dorsiflexion. We then flex the knee to relax the gastrocnemius and see if there's further dorsiflexion, which you can see very clearly here. This suggests that the gastrocnemius is tight, and depending on if the R1, R2 difference is more than 20 degrees, it would benefit from Botox potentially, and if less than 20 degrees, perhaps lengthening if appropriate for this child. Examination of the lower limb is completed with the child in the prone position. In this position, we will specifically test for rectus femoris tightness and also look at the rotational profile. As always, we follow a look, feel, move routine. So we look straight away and you can see there's some tilting of the pelvis, which is very clear. And more importantly, there are scars from previous surgical interventions, which look like the scars of both medial and lateral hamstrings lengthenings. The first thing that we will look for is for tightness of the rectus. And to do this, we will flex the knee and see if the ipsilateral side hip comes up. And you can see it comes up. Let me just show you that again. So we flex the knee and we see if the ipsilateral hip comes up. Okay. The second thing we will do is a rotational profile of the lower limb. To do this, we need to flex both knees. I will ask my assistant now to hold both tibia in this position. You can see very clearly that Mather has bilateral midfoot breaks with prominences of her navicular on both sides. We look at the curved border of the foot and we can see there's a convex border on both sides. This may give the impression of increased external tibial torsion when we start looking at the thigh-foot axis, but it's important to remember that we need to look at the transmalleolar axis on both sides to see if there's a significant rotation of the tibia. And in both of these cases, there doesn't seem to be. We look at the heel bisector line, which comes from the middle of the heel, and this should pass through the second ray, but you can see it's going towards the big toe, which suggests a valgus deformity of the forefoot, which fits with the midfoot break of the foot. I mentioned the thigh-foot axis, so let's have a look at that. So to measure the thigh-foot axis, we need two lines. The heel bisector line, which goes from the middle of the heel, and this should pass ideally through the second ray, which it does. And actually this confirms that the midfoot break is a reason for the deformity in the forefoot. And a line through the middle of the thigh here. And that angle is normally between 10 and 20 degrees. In Mather it's 15 degrees, which confirms that her tibial torsion is within normal parameters despite the deformities in the feet. The next thing that we look at, measure the transmalleolar line or the transmalleolar axis. This is measured from the medial and the lateral malleolus, this line here, and a line perpendicular to that, and this line is then compared to the line which goes to the middle of the thigh, and that is your thigh-foot axis. So the thigh-foot axis is normally between 10 and 20 degrees. So it will be the line subtended by, or the angle subtended between this line and a line in the middle of the thigh. The final part of the rotational profile is to measure the version of the proximal femur. This is done by internally rotating the proximal femur to see the anteversion. And so here, the angle is almost 90 degrees. And we compare that to external rotation of the hip, which is an indicator of retroversion of the hip. And for this, we keep an eye on the pelvis, and so we go externally rotated until the pelvis starts tilting, at which point we stop. About there. Thank you. So I'll just do that again for the video.
The examination will be concluded by examining the power in the lower limbs and thanking and helping the patient to go back to their chair. And this is bring us to the end of assessing a child with cerebral palsy and who is ambulatory. There will be one small video on how to document these findings in a smart table, but this will be covered with another video. I hope you find these videos useful for your exams and for your practice.